We are live, ma'am.
Yeah, thank you. So, good evening and a warm welcome to everyone joining us for yet another enlightening session of the Indian Thyroid Society's Thyroid Clinics webinar. So, before we begin today's session, let us take a moment to watch a brief video on the Indian Thyroid Society, which highlights our society's mission, our ongoing initiatives, and the impact to create awareness on thyroid health across the nation. I request the tech team to display the video.
तस्य भासाय सर्वमिदं.
Thank you. So, as we know, the thyroid clinics is currently being conducted under the dynamic leadership of Dr. Pramila Kalra Madam, who is the President-elect, and Dr. Roma Pradhan Madam, who is the Executive Committee member. Also, we have Dr. Narendra Kotpal sir, who is the President of ITS, Dr. Arun Menon sir, the Secretary, and Dr. Mini ma'am, who is the Treasurer, always inspiring us and guiding us. We also have Dr. Chitra Madam and Dr. Vijay Reddy sir, who are also part of the thyroid clinics. So before we start, I request Dr. Pramila Madam to give the opening remarks. Ma'am.
Hello.
Yes.
We can hear you. Am I audible? Yeah. Hello. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. So good evening, everyone. And I think this is another clinics and it's going to be very interesting. So we are going to discuss a very, very interesting case. And these clinics are meant for DM students, all practitioners, because everybody can learn from these clinics. And we also have an interesting talk coming up and followed by the quiz, which I know all the DM residents wait for. So without much delay, I think we can start off straight with the thyroid clinics.
Yeah. Sorry for that technical glitch. So a short announcement before we proceed. I request the tech team to display the QR code. So those who are interested to submit their research to the flagship journal, that is the Thyroid Research in Practice, can do so by scanning the QR code. And those who are interested to become reviewer for the Thyroid Research and Practice, again, can do so by scanning the QR code, which will help you sign up as a reviewer as well. So moving ahead with today's program. So as Madam has already said, we will have a very interesting case presentation by Dr. Kavya, who is the senior resident in the Department of Endocrinology, Ramaya Medical College. So the case discussion will be moderated by our distinguished faculty, Dr. Sri Nagesh sir and Dr. Muthukumaran Jaipal sir. We will then have an insightful presentation by Dr. Himagiri Rao sir, who will deliver a talk on reoperative thyroidectomy, followed by a quiz conducted by Dr. Anis Joseph at 8:50 p.m. So moving on, I'd like to invite Dr. Chitra Madam to introduce the moderators for the case discussion. So over to
Thank you so much, Dr. Ganavi. A very good evening to everybody joined here. This evening, we are glad to have two very, very important moderators with us. Welcome, Dr. Sri Nagesh. Dr. Sri Nagesh is a dear friend and an adult and pediatric endocrinologist at Sri Nagesh Diabetes, Thyroid and Endocrine Clinic in Hyderabad. And with him, we have Dr. Muthukumaran Jaipal to join us. He's the managing director at Arka Center of Hormonal Health in Chennai. Both of them are very well accomplished endocrinologists. Dr. Sri Nagesh has received numerous awards, the A.V. Gandhi Award in 2017, and he has close to 29 publications in peer-reviewed journals and close to 18 chapters. Dr. Muthukumar Jaipal is the president of the Endocrine Society of Tamil Nadu and Puducherry currently, and is the organizing secretary for ESICON and ITSCON in Chennai in 2026. Welcome, sir. And the presenter for the day is Dr. Kavya. We are proud to invite Dr. Kavya, who's a senior resident at the Department of Endocrinology, Ramaya Medical College, Bangalore. Over to you, Kavya.
Thank you, ma'am. Ma'am, are the slides visible? Shall I start, ma'am?
Ma'am, your screen is visible.
Okay. Can I start?
Please start, Dr. Kavya.
Okay. Good evening, everyone. Myself, Dr. Kavya, senior resident, second year in Department of Endocrinology, MS Ramaya. So today I'll be presenting a case of Miss A, who presented to us at the age of 5 years, 4 months. She presented to us with history of not gaining weight since 2 years and exaggerated gastrocolic reflex since 3 months. There was also complaints of increased perspiration and nocturia. With high suspicion of diabetes with these symptoms, an OPD glucometer GRBS was done, which was 89 milligram per DL. On further probing of the history, there was no history suggestive of short stature. There was no complaints of nausea, vomiting, or pain abdomen. There was no complaints of reduced appetite. There was no history of repeated hospital admission or no history suggestive of pancreatitis. So she was a second order child who was born out of non-consanguineous marriage by cesarean section. The birth weight was 2.2 kg and there is no history suggestive of any perinatal complications. There was a history of febrile seizure, one episode at the age of 2 years, for which she was treated, and there were no further episodes as such. Developmental milestones were achieved appropriate to age, and there was no family history suggestive of any autoimmune thyroid illness. So at the end of history, summarizing, she was a 5-year-old a 4-month-old child who presented to us with history of difficulty to gain weight since 2 years and exaggerated gastrocolic reflex, increased perspiration and nocturia, with no history suggestive of short stature, and with high suspicion of diabetes, which was ruled out by GRBS being normal. So hyperthyroidism was considered in this child.
Tell MT50 there is a.
Sorry, sir. On examination, the pulse was around 130 beats per minute, which was regular. BP was 96 by 56 mm of Hg, which was a 58th centile. Respiratory rate was 24 cycles per minute, and there was no pallor, icterus, or lymphadenopathy. Anthropometric examination, her height was 115 centimeters, which was on 75th to 97th centile with plus 1.3 of SDS, standard deviation, and weight was 15 kg, which was on 10th to 25th centile on the lower side with minus 0.6 of SDS. MPH was 151.5 centimeter, which was in the 25th to 58th centile with SDS being minus 1.1 standard deviation. Target height was 152.8 centimeter. The upper segment to lower segment was 1.18:1, which was appropriate for age, and arm span was 116 centimeter. Head-to-toe examination was done, which revealed hair was normal. There was no low set ears. Eyes, there was no prominence of eyes as seen in the picture, and there was no chemosis. Micrognathia was seen. Oral cavity, crowding of teeth was seen with malocclusion, and 5 permanent teeth were present at this age, which was accelerated teeth eruption, and hygiene was maintained. Goiter was palpated, there was a diffuse enlargement, which was soft in consistency, and there was no trill or bruit noted. Fine tremors in the hand were noted. Tanner staging was prepubertal, which was B1, P1, and A1. Skin, no changes were noted, and there were no cafe au lait spots noted. Spine was normal. There was no bony deformity, and clinical activity score was 0/7. Systemic examination, Cardiovascular system, the apex beat was noted at the fourth intercostal space, which was medial to mid-clavicular line. The S1 and S2 sounds were normal and there were no murmurs heard. Respiratory system, there were normal vesicular breath sounds heard. Per abdomen, there was no organomegaly. CNS, the deep tendon reflexes, bilateral knee was exaggerated. At the end of history and examination, 5-year, 4-month-old, to summarize, 5-year, 4-month-old female child with history of difficulty to gain weight, exaggerated gastrocolic reflex, perspiration and nocturia, and on examination, which revealed increased sympathetic activity in the form of tachycardia and tremors in hands, with height being on plus 1.3 STS and weight minus 0.6 STS, with accelerated dental eruption and presence of a diffuse goiter. Hyperthyroidism was a probable hyperthyroidism was considered as a diagnosis. Probable Graves' disease was considered since this is the most common presentation in children. Shall I go ahead with the investigations, sir?
Yeah, sure.
Okay. On evaluation, routine investigations, hemoglobin was 12.9 gram per DL. Total count was 11,440 with neutrophils being 51.5% and lymphocytes 39.7%. Platelet were 5,78,000. ESR was 6.6 mm per hour and calcium was 9.9 and phosphorus 4.2. Creatinine was 0.2, bilirubin was 0.4, with direct bilirubin being 0.1 milligram per DL. AST and ALT were 37 and 36. Alkaline phosphatase was 252, which was normal for age and gender specific. Albumin was 4.1 gram per DL. Electrolytes, sodium was 136, with potassium being 4.8. Amylase and lipase were normal, 59 and 25 respectively. The thyroid profile, TSH shows there was a significant suppression of TSH noted, which was less than 0.01. T4 was elevated 2 times the upper limit of normal, that was 24.40 microgram per DL. T3 was also elevated 2 times the upper limit of normal, which was 4.75 nanogram per ml. Urine routine was normal and prolactin was 9.8 nanogram per DL. Bone age was done and it was calculated by GP chart, which was 8 years, which was accelerated to the chronological age. The predicted adult height is 149.4 to 153.3 centimeter, which is lower than the mid-parental height. USG neck was done, which showed enlarged gland with increased vascularity, and there were no nodules noted. Beta HCG was done, which was normal. So we went ahead to confirm the diagnosis and the cause of hyperthyroidism, and technetium pertechnetate scan was done, which showed a total thyroid uptake of 8%, which was elevated, and there was diffusely increased trapping function in both the lobes, which was suggestive of Graves' disease. The patient was started on tablet methimazole 5 mg BD, which was around 0.66 mg per kg per day, and propranolol was started in view of sympathetic symptoms 10 mg per day, which was also 0.6 mg per kg per day, and vitamin D was replaced with calcium supplementation. Patient was asked to review after 6 weeks. At 6 weeks of follow-up, patient had the complaints of nocturia and the exaggerated gastrocolic reflexes were reduced. Weight was 16.8 kg, which was increased by around 1 kg. The pulse was 88 beats per minute, which was normal. TSH was still suppressed, being less than 0.01. T4 and T3 were in the range. And tablet methimazole was down titrated to 0.44 mg per kg per day. And since patient did not have any sympathetic symptoms, sympathetic overactivity symptoms, the propranolol was stopped and calcium and vitamin D continued. So this was the regular follow-up of the child, which we had, though all the follow-ups are not shown here. The child was regularly evaluated, and at around 2 years of on compliance of ATD also, the patient had a relapse of the hyperthyroidism biochemically and mild symptoms, where TSH was suppressed to less than 0.01 and T4 was 12.9 and T3 was 3.05, which was elevated more than T4. At this time, patient was down titrated to 5 mg per day tablet, that was 0.22 mg per kg per day, and she had a relapse. So patient was put back to 7.5 mg per day tablet. Till now, currently the patient is in euthyroid state with recent follow-up in September, where TSH was 2.59 and T4 and T3 in range. And currently she is on 10 mg and 5 mg alternate day, that is 7.5 mg per day. So currently she's 9-year-old with height of hers being 130 centimeter, which is minus 0.6 SDS, which falls in 25th to 58th centile in the part of the mid-parental height, and weight is around 27 kg, which is 50th centile. Recently, we got a trap as it was not done in the prior due to few financial and technical constraints, and it is 1.5, which is in the normal range. So our further plan is to continue anti-thyroid drugs and regular follow-up of the patient, and to see if the hormones are still in the euthyroid levels, to slowly down titrate the anti-thyroid drugs. And since the TRAb is in the normal range, and if the euthyroid level is maintained, try to taper and stop anti-thyroid drug and give a trial of stoppage of anti-thyroid drug further, and see for if and further prolonged follow-up is required for the child.
Dr. Kavya, just one question out of the history.
Yes, ma'am. Yes, sir.
You have given a few symptoms, but did the mother notice any change in the child's behavior or anxiety or anything like that? Or?
No, sir. Mother did not notice any change in the behavior or any altered behavioral symptoms or hyperactivity symptoms. Even on probing of the history also, mother did not complain of any such symptoms.
And academic performance change as well, hasn't?
Now the academic performance is good, the scholastic performance is good, but at presentation she was just 5 years and 4 months. The scholastic performance could not be assessed as at that time, but currently the scholastic performance is good, and there was no in the throughout follow-up there was no dip in the scholastic performance as noticed by the parents.
Yeah, I've got one question for you. You said you would perhaps try to taper and, if possible, stop the medications for the child.
Yes,
what do you
sir.
think is your probability of actually taking the child off medication? Now she's probably around 9 or 10 years old, right?
She's 9 years old, sir.
Yeah.
Yes, sir.
So what do you think is the probability? What is the remission rate you'd expect at this age?
Sir, usually in childhood graves, the remission rate is very low, which
How
is
much?
noted, which is around only 20% at the end of ATD duration of 2 years. And there are few remission characteristics by which we think there might be remission or there might not be remission, like younger age group of presentation, higher TRAb and higher free T4 at the presentation, then still TRAb positivity and Caucasian race and male child. These all patients are in favor of not remission and relapse after ATD withdrawal.
Okay. So generally below the age of 10 years, the remission rate is hardly, it's not even 20, it will be around 10 to 14%.
Yes, sir.
Once you hit puberty, the remission rates start going beyond 20.
Yes, sir.
Once you reach an age of 25, they'll be around 30 to 40. It's only after you hit an age of 50 years that the remission rates go beyond 50%. Second, you tend to have less florid hyperthyroidism because you have an apathetic hyperthyroidism. So at this age, the kind of remission you would perhaps expect in this patient is, in 90% of the cases, the minute you either decrease the dose or you stop it, she's going to relapse. Irrespective of the TRAb antibodies, and that is what has happened in your case.
Yes, sir.
The next corollary question to this is, why do you think this happens? Why do children have a lesser chance of having a relapse?
the lesser chances of relapse are it is seen that in children the initial presentation only is in a florid state compared to adults, and also the one is at the presentation there is a florid hyperthyroidism, and also there is a slight delay in diagnosis of hyperthyroidism in children, and also the immunity, the immunomodulatory, the autoimmunity is more in this age group. So that is why the remission rate in children has been less.
Yeah, that's a good point, but if you allow me, I'll slightly elaborate on this.
Yes, sir.
Basically, what happens is the immune system at this age is a bit immature.
Mm.
The immune regulation is immature. The mechanisms which protect you from autoimmune damage are less well developed. So you have a more persistent and a higher TRAb antibody production.
Yes.
Second, because they're children and they have a very fresh immune system, the B and T cell memories tend to be long.
Mm.
They have a very strong B and T cell memory, sustained memory, which leads to prolonged stimulation of the thyroid tissue. And that is the reason why the TRAb antibody titers remain positive. In your case also, the TRAb has come down because she's on methimazole.
Yes, sir.
The minute you take the child off methimazole, the TRAb will again start rising. And like you pointed out, children usually present later.
Mm.
Diagnosis, you generally don't expect. Graves' disease, hyperthyroidism is slightly less common in children. So that is never the first diagnosis which people think about when somebody presents with obesity, when somebody presents with weight loss. They'll usually think of either diabetes as you thought of it right now, or you will actually consider some other intolerance or even celiac disease, though that is pretty uncommon among South Indians. The second thing is what this delay does is you generally tend to present with a more severe disease where the goiter is larger.
Mm.
And you have more, because of the delay in diagnosis, you have more lymphocytic infiltration, more thyroid destruction, more release of antigen, and more development of antibody. And that is why the remission rates are much lower in children as exposed to adults. Also, the dose of carbimazole or methimazole is slightly higher in children because children tend to have metabolize these medicines rapidly. So to have an immunomodulatory effect, it takes a longer time.
Yes.
And regenerative potential. Generally, what happens is, to give you a perfect example, older people tend to have less severe and lesser long-lasting hyperthyroidism because their regenerative capacity is decreased. Once there is an autoimmune destruction or damage of the thyroid gland, they have less ability to regenerate. Children have a better ability to regenerate. And that is the reason why they generally tend to relapse earlier and they tend to have more persistent and sustained hyperthyroidism. After puberty, there is some amount of immune tolerance, and that is why there is almost a doubling of the remission rate.
Yes.
So your value of 1.5 does definitely warrant a trial at withdrawing of the methimazole once the TSH starts rising. But in all probability, you're not going to be successful. You might have to maintain it. The median period of maintenance of your antithyroid therapy will be minimum 3 to 5 years.
Yes.
Or in many cases, it might be long term. Long term means indefinite, till I ask you to stop. Essentially, till I ask you to stop or till they get tired of you and go to some other doctor who will give them a trial of these medications, have a relapse, and again go back to the same medication.
Yes.
This is what usually happens in clinical practice.
But they've already taken it for 4.5 years already. So
some more times. More times. I don't think I've rarely ever seen hyperthyroidism at this age remit.
I agree. I think I would agree with the same thing. I wouldn't want to stop it at all. I'd like to continue the antithyroid drugs in this kind of age, especially when they're growing. And if there is no indication currently, unless the TSH starts rising and you want to stop it, there is no valid reason because it will help their growth, maturity, and so on during their peripubertal age. So it will be in the patient's best interest to continue everything as long as they're needing a low dose antithyroid drugs. So they will continue to be under your supervision. And as Dr. Nagesh suggested, when things are a bit more stable, probably when if the TSH rises at all, then we can give a trial. If not, then they might have to continue it. That's what I would agree with the same, because 5 years is a little bit too early. and less than 10, it's probably just around you have normalized it. So you want to continue it and do whatever you can for the patient. Yeah.
Yes.
And
Okay,
one
sir.
small observation about the treatment you're given the child. Your
Yes, sir.
vitamin D doses. Why did you give her vitamin D weekly once for 8 weeks? What was the weight at the time of initiation of therapy?
She was around 15 kg, sir.
Yeah, the dose is a bit on the higher side. The
Okay,
cutoff
sir.
for a child is the TSH, the vitamin D normalcy, sufficiency for a child is not 30 nanograms per ml, it's 20.
Okay, sir.
12 to 20 is insufficiency range. Anything above 20 is normal. So if you put her on 8 weeks of vitamin D, 60,000, 50,000, 60,000 units, you're probably going to lead to a state of hypervitaminosis. And
Okay,
the
sir.
other thing is, though it's not universally practiced, I generally, during florid hyperthyroidism, I never start them on calcium. Because in rare situations, that might lead to nephrolithiasis. You already have excess bone resorption, the
Excess
serum
bone.
calcium levels are high. And if you give them superadded calcium, that might cause a situation where there is more filtration of calcium through urine. There is more calciuria, hypercalciuria, and you end up with a small nidus, which can lead to nephrolithiasis. Once the thyroid levels have whitened down, T4 and T3 are come back to normal, because TSH usually takes up to 6 months before it comes back to normal. I would not start them on calcium. You can give them some dietary forms of calcium. You can give them sesame seeds, you can give them milk. A lot of things which are good dietary sources of calcium, because dietary calcium excess, even if you got a dietary calcium excess, it rarely if ever leads to nephrolithiasis. The medication, I would be a bit circumspect about it. There are no clear-cut guidelines, but this is my practice.
Okay, sir. Shall I go ahead, sir?
One last, if you have any other, are you going ahead with the case?
No, sir. This is it. Just the review of literature and few points.
One last question I had here was,
yes, sir.
Would you consider radioiodine therapy in this case? If yes, why? If not, why not?
Sir, radioiodine therapy in less than 10 years is usually a relative contraindication.
Yes.
And since the patient currently now is stably maintained on antithyroid drugs, so I would like to continue with the antithyroid drugs. And even over prolonged period of this 4.5 years, there was hardly one relapse of the hyperthyroidism, that too due to down tapering of antithyroid drugs. And since the patient is has not developed any even minor side effects to antithyroid drugs, I would still feel that antithyroid drugs can be continued for the child with the age.
Yeah, that's absolutely right. And one other point is, if you're giving the child radioiodine therapy, let us assume she's 15 and you're giving her radioiodine therapy, you're converting her into a patient for life.
Yes, sir.
She'll have to be on some form of replacement for life. She'll have to be on thyroxine for life. Here, even though the theoretical possibility is less, there is always a chance that at some point of time or the other in her life, she'll be off medication. If you give her radioiodine, you have converted her into an endocrine patient for life, which we don't want. So, it will always, as long as she doesn't have any side effects or adverse reactions with the antithyroid drugs, we can give, because even in adults nowadays, similar to what we see in children, we are no longer so aggressive or so bullish about giving people radioiodine therapy. We just wait and watch, and even very low dose carbimazole therapy and very low dose methimazole therapy has come into use. Now, I think a few months down the line, even a few of the pharma companies are going to come up with 2.5 mg of carbimazole and methimazole. They've already taken DCGI approval for that. So, radioiodine has kind of fallen out of favor right now.
Yes.
At least definitely not in this case.
Yes.
That is a very good call. Please go ahead.
Couple of things, Dr. Kavya. I saw you putting Indrol just there as one-off dosage. When you give a beta blocker, we would expect if you're giving a short-acting beta blocker, we'd get it multiple times a day. That's one thing. Or you might, obviously with the dose related to the weight, but 10 mg might be not very conducive. I would probably do it twice a day at least, rather than just once a day. I'm the other feedback with your titration is I'm more comfortable in, especially in Graves' disease, with free hormone titration. But again, it depends on where you live and how good your free hormones are. But with regards to titration, it's a little bit more useful when you go by free hormones than total hormones, because otherwise you end up with the early hypo sometimes, which will not be undetectable. So those are one thing. But if your lab is not that good enough, or if you work in the periphery, then you have to work with what you've got.
Yes.
Dr. Nagesh, do you use free hormones or total hormones in your?
I use total hormones, sir, because the problem with using free hormones is one, the accuracy of reports. The second, you have a problem of clockwise hysteresis. That's a phenomenon not commonly studied, but using free hormones in hyperthyroidism can lead to clockwise hysteresis. That's a biochemical phenomenon. So generally, wherever possible, I try to use total hormones. We've got a couple of questions from the audience here. Chitra's posted a couple. How much does the acceleration of growth affect final adult height in children with Graves? Your comments on this, please. What is your observation?
Sir, it has been like one study which has been published, which took 9 patients were studied with hyperthyroidism. They have seen that although the bone age is accelerated during the period of hyperthyroidism, but the adult age was not compromised in these patients.
No, actually, adult height can be compromised. Basically, what happens is you've got rapid skeletal acceleration and rapid skeletal fusion. So the final height, very similar to what it's seen typically in CAH, you'll have decreased final adult height. So because of that, I do not think if you do not control it, final height being affected is another problem you'd see with hyperthyroidism. Because for 2 reasons. One, you have a rapid maturation of the growth plate.
Yes.
Second, you got more production of IGF-1 from growth hormone, from the growth hormone mediated actions on the liver. Higher IGF-1 is produced, which causes a rapid maturation of the chondrocytes, but the final height will be impaired. That is one more reason why we need to treat hyperthyroidism aggressively. Otherwise, the final height will be compromised in these children. And what were the differential diagnoses you would have had in this case, other than diabetes? Because I've seen you've done some other tests, a couple of other tests in the evaluation. You've done a beta HCG. What was your rationale for doing a beta HCG in this case?
Very rarely, HCG secreting tumors can cause hyperthyroidism.
Yeah, that is a very pertinent
and
point.
Also due to accelerated bone age, any precocious puberty, though her Tanner's was normal.
Yeah, I'm not able to hear you.
Sir, accelerated bone age, so which is also seen in precocious puberty. Beta HCG secreting tumors, precocious puberty, and accelerated bone age. Though her Tanner's was not pre-pubertal, sir. There was no signs of this thing. And also, a very rare case of HCG secreting tumors can lead to hyperthyroidism in children.
Okay, and the other thing is you've done a scintigraphy here. Generally,
yes,
it's a toss-up between doing a scintigraphy and
trap.
This is doing a trap. Because of reasons of cost, we generally can't do both. I prefer doing a scintigraphy. Because scintigraphy also tells you about autonomously functioning thyroid nodules, though they're not common in this age. AFTN cannot be picked up on trap. So that is the reason I generally prefer not doing a trap. And like I've mentioned many times in our groups also, I have my own doubts about the veracity of a few of the trap reports done by commercial labs. Some give very good values, some don't give really all that good values. One other question I had about this was, suppose let us assume you had an HCG-mediated thyrotoxicosis or some other cause of hyperthyroidism. What would have been the thyroid scan pattern? How would you have made it out? Even though you don't do a trap, even in a scintigraphy, you can actually make out whether this is mediated by innate hyperthyroidism because of TRAB or is it because of HCG or some other cause. What is the scintigraphy pattern you would observe in each of these cases?
Not sure.
I will tell you. Basically, because in Graves' disease, TRAB causes increased uptake of iodine. There is intense reception of the TSH receptor via TRAB. It upregulates the sodium iodide importer activity, basically because iodine is entering into the cell through the sodium iodide importer. So you will have diffuse uptake, uniform uptake, the kind of brilliant uptake you had right now. This is what is classically seen in Graves. You can have nodularity, but nodularity is usually seen more often than not in older people. Even in Graves, you can have nodularity. Nodularity disorders like Marine-Lenhardt are seen more in adults. HCG, because of its homology, this is somewhat like the specificity spillover you would actually see with other hormones. Because of the structural similarity it shares with TSH, whereas the alpha subunit is identical here and beta subunit is also pretty homologous. There's only a 3 or 4 amino acid difference between these. Very high HCG levels, like which are secreted in typical HCG secreting tumors like German amos, can stimulate the TSH receptor, which will also cause increased thyroid hormone production. But the uptake is never uniform. It is never so intense that it can stimulate the NIS receptor. So you will often have a patchy uptake, or one area might have uptake or high normal uptake. You will never have the typical diffuse high uptake, which you actually see in a classic Graves' disease. So that is a soft pointer towards differentiating whether this is an HCG-mediated thyrotoxicosis or Graves, and you can always back it up by doing an HCG test. In thyroiditis, the other entity, you got two entities here. If you want to differentiate with scintigraphy, you either got a Hashimototoxicosis or you got a subacute thyroiditis, both of which are fairly common in children at this age, especially after viral fevers, commonly Epstein-Barr virus and parvovirus and related viruses. You will have a low uptake because of thyroid damage. All the hormone has actually been extruded from the cell. The thyroglobulin and the hormone has been extruded from the cell. So you will have low uptake because of damage to the thyroid follicular cell, but the thyroid hormone levels will be high. And it will always be patchy. It will not be uniformly diffuse. Toxic multinodular goiters are again not so common at this age because they do take some amount of time to actually develop. AFTN is also not very common in children. In a majority of cases, whenever you're looking at thyrotoxicosis in a child, you're either looking at an autonomously, either looking at Graves' disease or you're looking at a thyroiditis. More often than not, it will be a subacute thyroiditis. Rarely, it can be a Hashimototoxicosis. It's a term which is not commonly used nowadays, but sometimes Hashimoto's thyroiditis doesn't always typically present with a hypothyroid phase. You can have a brief hyperthyroid phase. Often, it will be there only once in the lifetime. Very rarely, you can see 2 or 3 episodes of this kind of Hashimototoxicosis-like picture, and later on, it settles into hypothyroidism. So this is how you would use a typical scintigraphy. So, and always make sure that you always have a look at the picture rather than looking only at the radiologist report, because at nuclear medicine specialist reports, because at times they have been known to err. Just like we look at the bone age X-ray, where their radiologists are often known to err, this causes a problem where many a times they are known to err. So make sure that you corroborate the report after you don't depend solely on the nuclear medicine specialist report.
Okay, sir.
Can you go on to the literature survey now?
So a few points about Graves' disease. This is the most common cause of hyperthyroidism in children, with incidence being 4.5 per 1 lakh, whereas less than 15 years, it is still rarer, like 1 to 2.9 per 1 lakh. Girls to boys ratio is 1.4:1. The clinical features are usually tachycardia, goiter, diarrhea, and loss of weight. There can be delay in diagnosis due to the varied presentation in children, like impaired concentration capacity, attention deficit hyperactivity disorder, and poor scholastic performance. The other rarer presentation in children, like tall stature, accelerated bone maturation, and reduced mineralization. Eye symptoms, proptosis can be seen, but usually the eye disease compared to adults is mild disease. The inflammation is less. Treatment, usually antithyroid drugs are the first line of treatment with minimum duration of 3 years, and it should be and up to 5 years in patients with unfavorable characteristics for remission, as we discussed, like large goiter, more than 80 gram, elevated free T4 and TRAB at diagnosis, non-Caucasian race, and younger age. Remission is less than as compared to adults, with 20 to 30% after 2 years of antithyroid drugs. A study by Legger et al. Showed that continued antithyroid drugs over years improved the remission percentage. So definitive therapy like radioiodine ablation and total thyroidectomy are usually considered when there are severe side effects to antithyroid drugs or unable to report side effects, relapse, or long-standing poor compliance. So with comparison of radioactive iodine and total thyroidectomy, radioactive iodine is absolute contraindication with less than 5 years and active Graves' ophthalmopathy with relative contraindication in 5 to 10-year-old child and large goiter with more than 80 grams. Total thyroidectomy is indicated in these patients with large goiter and child less than 5 years. The time to hypothyroid state is usually weeks to months after radioactive iodine, and it is rapid achievement in total thyroidectomy. The risks are very rare risk of neoplasia risk with radiation after radioactive iodine ablation, and total thyroidectomy. It is usually the post-op complications like hypoparathyroidism and recurrent laryngeal nerve injury, which are seen in children, which are increased compared to those of adults. So the learning points are Graves' disease is the most common cause of hyperthyroidism in children. There can be a diagnostic delay because the symptoms can be usually attributed to gastrointestinal, cardiac, or psychosocial abnormality. And ATD is a first line of management, which requires a prolonged treatment compared to adults, and remission rate is less and prolonged follow-up is required. So this was a case series which was done at Indira Gandhi Institute of Child Health, Bangalore, which studied the clinical characteristics and treatment pattern in 47 children, where they which had 66% were girls, and the mean age of presentation was around 12.79 to plus or minus 3.75 years. The usual presentations were heat intolerance, excessive sweating, palpitation, exophthalmos, which was noted in 48% of people, tremors, and others were like constipation, hoarseness, and weight loss in other individuals. The goiter was seen in around 87.3% of people, which constituted diffuse goiter in 80% of people. And the carbimazole and carbimazole dose which was used was 0.46 mg per kg per day, and methimazole was 0.29 plus or minus 0.14 mg per kg per day. The treatment duration in this case series was around 2 years plus or minus 1.53 years, and the mean time to achieve euthyroid was around approximately 4 months. Remission was seen only in 2 children, that was 4.3% at the age of treatment duration of 2.5 years, and 13 individuals, that is 27%, underwent radioactive iodine ablation, with 1 patient who underwent total thyroidectomy who are on LT4 supplements. So this was another case study of in identical twins who was a 6-year-old girl who presented with increased thirst and urinary frequency over past 6 months. In this case also, diabetes was suspected and glucose readings were taken, which was around 80 to 180 milligram per DL. She also had secondary nocturnal enuresis, and there was a strong family history for autoimmune thyroid disease. The growth on examination, she had a height in 75th to 98th centile, weight being on the lower centile, 25th to 58th centile, with the symmetrically enlarged goiter was seen with no nodules in cervical lymphadenopathy. On laboratory evaluation, HbA1c was 5.4 and diabetes was ruled out. And she had a suppressed TSH with elevated T4 and T3, and TRAB was positive. She was started on methimazole, and after a few weeks, this polydipsia and polyuria was resolved. So this case was a similar presentation to as our child, which had a rare presentation of polydipsia and nocturia, which are the rarer presentation of hypothyroidism in children. So there can be a delay in diagnosis. So the proper history and examination and evaluation can lead to early diagnosis, and early treatment may have a better outcome in these children. Thank you. So I'm not able to hear, sir.
That was a very good presentation, well presented and well done. I think
Thank you, sir.
on behalf of all the Dr. Nagesh and Chitra has also gone. Chitra, are you there?
I'm here, sir.
Yes, yes. On behalf of the team, I congratulate you and thank you for the nice presentation.
Thank you
Thank
so
you,
much.
sir.
Thank you.
Tanvi, you are muted, muted. You are muted.
Yes, ma'am. Thank you, Dr. Kavya, for that excellent and insightful case. And I thank the moderators, Dr. Sri Nagesh sir and Dr. Muthukumaran sir, for leading the discussion in an excellent manner. So next, I'm pleased to welcome Dr. Vijay Bhaskar Reddy sir, who will be introducing our quiz master. So there's a slight change in the program. So instead of the presentation by Dr. Himagirish Rao sir, we will have the quiz first, followed by the presentation later. So, since it is one of the most awaited segments of the ITS Thyroid Clinics, that is the thyroid quiz, I request Dr. Vijay Bhaskar Reddy sir to introduce our quiz master, Dr. Anis Joseph. Over to Dr. Vijay Reddy sir to introduce our quiz master.
Thank you, Dr. Pranavi. I think we proceed with the quiz for today. The quiz master will be Dr. Anis Joseph. She is Assistant Professor, Department of Endocrinology, MOSC Medical College, Kolancheri. And she's got multiple achievements. She's got MGR University Gold Medal for DM Endocrinology and Dr. V. Mohan University Medal for DM Endocrinology. She's got 15 index publication esteemed journals she's winner of first prize in multiple oral presentations at ASICON, Trendo 22, ISBMR conferences. And she secured multiple awards for poster presentations at ISBMR and Trendo. Over to Dr. Anis Joseph.
Thank you, sir, for that kind introduction.
Ma'am, you can read out the quiz questions, ma'am, quiz rules, and I'll give you the cue when to go on to the next question, ma'am.
So good evening, everyone. This is the quiz rules. To participate in quiz, click on the button given on the screen, which is being live streamed. The quiz will be conducted through a platform called Slido. You're requested to use a laptop or for ease of experience. Quiz will run for 5 minutes. The quizmaster will display case or description of question by screen sharing a PowerPoint file. There will be a total of 10 questions and each questions will be available only once for 30 seconds with the timer on. Kindly do not refresh the page or go back onto the page. Can I share the slide?
Yes, you can share the screen, ma'am, and be ready. I'll give you the cue when to start, ma'am.
It'll take some time for people to log on. So
Yeah.
you can.
You can go to the slide mode, ma'am. Slideshow.
Is it visible?
Yes.
Yes, ma'am, it is visible.
Once people log on, they will let us know when to start.
I think we can start, ma'am. Yeah. I'll give you the cue for the next question, ma'am. You can just, yeah.
Okay. Yeah. So our first question is, which form of iodine is recommended for fortification due to superior stability in humid climates? Option number A, potassium iodide, B, potassium iodate, C, sodium iodide, D, sodium iodate.
Ma'am, next question.
So the second question is again on iodine fortification. The upper limit of 30 ppm iodine at production level was introduced mainly due to answers. Options are match global WHO recommendation. Option B, avoid subclinical hyperthyroidism in elderly population. C, to reduce the cost of fortification. D, improve iodine stability in packaging.
Ma'am, next question.
So there was a recent study which was published on low dose versus high dose of carbimazole for hyperthyroidism. It was found that it produced similar euthyroid conversion rates at the end of 4 to 6 weeks. So which is the possible mechanism for this equivalence? Option number A, saturation of intrathyroidal peroxidase inhibition at dose more than 15 milligram per day, or reduced bioavailability of carbimazole at higher doses due to first pass metabolism. Option number C, upregulation of hepatic deiodinase activity at lower dose. And option number D, dose-dependent stimulation of TSH receptor antibody clearance.
Madam, next question, ma'am.
Question number 4 is, the coronary drug project with D-thyroxine was stopped early because of option A, lack of LDL reduction, B, increased mortality in the treated group, option C, hepatic failure, option D, agranulocytosis.
Next question, ma'am.
Question number 5 is, which experimental thyromimetic showed potential neuroprotective benefit by enhancing oligodendrocyte differentiation? Is it sorbitolol, triac, eproterol, or resmetirom?
Next question, ma'am.
Question number 6. How does the thyroid hormone levels correlate with severity scores in chronic liver disease? Free T3 and option number A is free T3 and free T4 positively correlated with severity of liver disease and TSH negatively correlated. Option number B is free T3 and free T4 negatively correlated. However, TSH positively correlated. Option number C is all had positive correlation with severity of chronic liver disease. And option number D, there was no correlation observed.
Next question, ma'am.
Question number 7 is, which of the following statement about reoperative thyroidectomy is true? Option A, risk of recurrent laryngeal nerve injury is less than 2% in expert hands. Option number B, hypoparathyroidism risk is comparable to primary surgery. Option number C, intraoperative neuromonitoring is recommended for nerve identification. Option D, fibrosis is less severe if reoperation occurs after 10 years.
Next question, ma'am.
Question number 8 is, a 17-year-old male undergo completion thyroidectomy for residual Graves' tissue. How does carbon nanoparticles mapping help to reduce permanent hypocalcemia? Is it selective staining of parathyroid or negative staining of parathyroid or enhanced vascular perfusion of parathyroid or stimulated PTH release intraoperatively?
Next question, ma'am.
Question number 9. Which genetic association has been most strongly linked to pediatric Graves' disease? Is it HLA-B8, CTLA-4 polymorphism, or PTPN22 mutation, or TSH receptor gene variant?
Next question, ma'am.
The question number 10. Which of the following is the first-line targeted therapy approved for red mutant medullary thyroid cancer? Option number A, cabozantinib. Option number B, vandetanib. Option number C, selpercatinib. Option number D, pralsetinib.
We are done, ma'am.
Can discuss the answers now. Shyam, you can get the final winners list also.
1
Yes,
minute.
sir. I'm sharing it to you, sir. Yes.
Just sharing the screen.
After we discuss the answers.
Okay. Is the screen visible, sir?
It's visible. You make it full screen. Animation.
I'm not able to share it screenshot. Sorry.
Go to slideshow. Yes.
Can I discuss, sir?
Yes.
So the first question was, which form of iodine is recommended for fortification due to superior stability in humid climate? The option is option B is the correct answer, which is potassium iodate. So there is, as we all know, there is a thyroid research and practice journal where there was a review article on Indian Thyroid Society expert consensus on salt iodization. It's a very beautifully written article where they have mentioned the iodine fortification, the challenges and all. So potassium in a country like India, where a tropical country like India, because of the excessive humidity and heat, potassium iodate is the most stable compound which is preferred for iodine fortification in India. So the second question is, the upper limit of 30 ppm iodine at production level was introduced mainly due to, this is to avoid subclinical hyperthyroidism in elderly population. This is the reference for this has also been taken from Thyroid Research and Practice Journal. There is increased level of iodine can be associated with thyroid disorders, especially in patients in iodine deficient population and vulnerable population like elderly people. So high iodine intake may precipitate iodine induced thyrotoxicosis in elderly and also in patients with autonomous nodular goiter. So this 30 ppm cap will mitigate this risk. That's why the cutoff for iodine fortification limit of 30 ppm is being mentioned. So the third question was, a recent study on low dose versus high dose carbimazole for hyperthyroidism produced similar euthyroid conversion rate at the end of 4 to 6 weeks. So what is the mechanism? So from the literature, it is found that the saturation of intrathyroidal peroxidase inhibition occurs at doses more than 15 milligram per day. So hence, this is a recently published article in Thyroid Research and Practice Journal, where they have looked at the efficacy of low dose and high dose carbimazole in the treatment of Graves' thyrotoxicosis. And at the end of 4 to 6 weeks, they found that both low dose and high dose group had around 85%, like 86% of the patients in the low dose group and 85% in the high dose group were showing comparable early efficacy in terms of control of hyperthyroidism. So the fourth question was, the coronary drug project with D-thyroxine was stopped early because of. So this was the answer for this question is increased mortality in the treatment group. So as we all know, the coronary drug project was in the later 1960. This was a clinical trial which had looked at the efficacy of D-enantiomer of thyroxine as a lipid modifying agent in patients with coronary heart disease. They found that it was the use of D-thyroxine was associated with good efficacy in control of lipid profile, but however, there was increased mortality was associated with with the use of this drug. Hence, this trial was early stopped because of the increased mortality among this population. So the next question was, which experimental thyromimetic showed potential neuroprotective benefit by enhancing oligodendrocyte differentiation? The answer for this question is sorbitol. This is also from a review article which was published in Thyroid Research and Practice. The thyromimetics, hope or hype. SOAP AM2 is a prodrug of sorbitol. It increases it penetrates the blood-brain barrier within the CNS. It gets converted into sorbitol at high level, and it stimulates the differentiation of oligodendrocyte precursor cells and remyelination in a mouse model. And the next question is, how does the thyroid hormone levels correlate with severity scores in CLD? So the answer is, free T3 and free T4 were negatively correlated, whereas TSH positively correlated with severity of chronic liver disease. This is also from this question has also been taken from an article which was published in Thyroid Research and Practice, where they have looked at the thyroid dysfunction in chronic liver disease and its correlation with severity of liver disease. They found that the most common abnormality seen in these patients with chronic liver disease was low T3 syndrome. And in all CLD patients, the free T3 and free T4 levels negatively correlated with severity of chronic liver disease, whereas TSH positively correlated with severity of chronic liver disease. The next question is, which of the following statement about reoperative thyroidectomy is true? So reoperative thyroidectomy, it is essential to monitor. Intraoperative neuromonitoring is recommended for nerve identification in order to prevent the recurrent laryngeal nerve injury. So reoperative thyroid surgery carries a significantly higher risk because of dense fibrosis, distorted anatomy, and loss of tissue planes. So hence, intraoperative neuromonitoring is strongly recommended to prevent the recurrent laryngeal nerve injury. So the reported recurrent laryngeal nerve injury rates in reoperative cases are in around 4 to 8% can have transient recurrent laryngeal nerve injury, whereas 3 to 5% of the cases, even in expert hands, can have permanent recurrent laryngeal nerve injury. But whereas it is less than 1% in the primary surgery. And permanent hypoparathyroidism is almost 3 to 5 times more frequent than the primary surgery. So going to the next question, how does carbon nanoparticles mapping help to reduce permanent hypocalcemia? The answer is negative staining of parathyroid. So these carbon nanoparticle molecules, the nanoparticles stain lymphatic and thyroid tissue black, but not parathyroid. So hence, it makes them stand out as an unstained structure. Hence, we can facilitate the preservation of their blood supply. So there were recent studies and case reports on use of carbon nanoparticle for identification of parathyroid gland. It was found that the use of carbon nanoparticle assisted thyroidectomy significantly reduced permanent hypocalcemia and shortens operative time, especially in redo surgeries. Coming to the next question, which genetic association has been most strongly linked to pediatric Graves' disease? The answer is TSH receptor gene variant. So TSH receptor gene is located in chromosome 14q31. It has if there is a polymorphism in the ingrown 1 region, it influences the central tolerance and TSH reception in the thymus, which can predispose children to have autoantibody generation against the TSH receptor, which can lead to hyperthyroidism. The next question is, which of the following is the first-line targeted therapy approved for RET mutant medullary thyroid cancer? The answer is selpercatinib. So selpercatinib is a selective RET inhibitor approved for advanced or metastatic RET mutant medullary thyroid carcinoma. Compared to other multikinase inhibitors, it had superior efficacy and safety. Hence, this is the approved treatment for RET mutant medullary thyroid cancer.
Thank you, Dr. Anis. Shyam, we can have this results of the quiz.
Yes, sir. I'm just sharing the screen.
Okay, so first prize goes to Dr. Sanjana. Second prize, Dr. Priyanka, and third one is Dr. HSK. HSK, we don't know the full form. We'll contact by phone. So all the winners will get a certificate of appreciation from the Indian Thyroid Society. Congratulations to all the winners. We'll have a short discussion of the practitioners quiz, which was conducted online. Dr. Anis, you can have a short discussion, then we can go to Dr. Himagiri's talk.
Sure. So next we will have a discussion on practitioners quiz, which was conducted online. The first question was, what percentage of Indian households currently consume adequately iodized salt? The answer for this question was 75%. So if you look at the National Iodine Survey of India, which was again published in Indian Thyroid Society Expert Consensus on Salt Iodization, it was found that 92.4% of the population were consuming iodized salt, while only 76% were consuming adequately iodized salt. So what do you mean by adequately iodized salt? Iodine in salt more than 15 parts per million. So the adequate iodine consumption was only 75% according to the National Iodine Survey. So the second question was, which factor is most predictive of progression from subclinical to overt hypothyroidism? That obviously the presence of anti-TPO antibody positivity. So the third question was, which thyroid status is most commonly associated with thyroid disease? It is hyperthyroidism, which is most commonly associated with thyroid eye disease. And question number 4 is, in the context of Graves' disease, which of the following is a common ocular manifestation? Exophthalmos is the most commonly occurring ocular manifestation among patients with Graves' disease. There are n number of eye signs are there, but exophthalmos is the most common eye manifestation in patients with Graves' disease. So the next question is, what adverse pregnancy outcomes are associated with untreated thyroid dysfunction? Untreated thyroid dysfunction, especially hypothyroidism, can lead to increased risk of preeclampsia, preterm birth, fetal growth restriction. So the answer for this question is all of the above. This is also from a recent journal, which is published, a recent article, which is published in Thyroid Research and Practice. Where they have mentioned various complications such as miscarriage, intrauterine growth restriction, preterm delivery. All these can be associated with untreated thyroid dysfunction. So the next question, which of the following is true regarding thyroid disorders in pregnancy? So the answer for this question is, universal screening of all pregnant women in the first trimester is recommended. All patients when they come for the first time, we need to have a screening with TSH. So next question is, which demographic group shows a higher prevalence of thyroid nodule? So answer for this question is females. This is also from the recent article which was published in Thyroid Research and Practice Journal, where there was a consensus statement on diagnosis and management of thyroid nodules by the Indian Thyroid Society. And they found that the female patients constitute 93% of the cases among patients with thyroid nodule. And the male is to male ratio is 1:14. And the most common age group was between 31 to 40 years. So what is the approximate chance of malignancy in palpable nodules of multinodular goiter? So the answer for this question is 5%. So if you look at the solitary thyroid nodule, they have a higher risk of being malignant. The risk of malignancy in a solitary thyroid nodule is around 10 to 20%. Whereas in a multinodular goiter, it's compared to solitary nodule, it's slightly less. It's around 5%. Next question, what is the suggested initial diagnostic evaluation for a patient with thyroid nodule? The answer for this question is serum TSH. This is again from the consensus statement of the Indian Thyroid Society on diagnosis and management of thyroid nodule. When you come across a patient with solitary thyroid solitary or multinodular goiter, the initial investigation that should be done is serum TSH. Then the serum TSH is the initial investigation that you should be doing. The next question, which system is recommended by Indian guidelines for reporting thyroid cytology? This is the Bethesda system. That is the cytological system which is being used for categorizing the risk in patients with thyroid nodule. So Bethesda system is widely used and it's been recommended by all the other guidelines as well. Thank you.
Thank you, Dr. Anis, for going through the discussion for the answers. Tech team, can we display the results of the practitioners quiz?
Yes, sir.
So the winners of the practitioners quiz, first prize goes to Dr. Mohammad Ghaus, second Dr. Subita, and third Dr. Sudha. Congratulations to all the winners, and you will get a certificate of appreciation from the Indian Thyroid Society through email. Thank you, Dr. Anis, for conducting the quiz for both the practitioners and for the DM residents. Next, we move on to the monologue for today. The topic is reoperative thyroidectomy. It will be presented by Dr. Himagirish Rao. Dr. Himagirish Rao is a professor of surgery, CDSI MER. Is Joint Secretary of ITS and Executive Committee member of Surgical Society, Bangalore. And he's got multiple achievements. Over to Dr. Himagirish.
Yeah, good evening, everybody. Thank you, Dr. Vijay Bhaskar Reddy, for the kind introduction. At the outset, I wish to beg your pardon because I had to reschedule my talk a little bit. I was supposed to start talk at 8:30 and I've been late. I would also like to thank Dr. Pramila and team for having given me this opportunity to come on the thyroid clinics. It is indeed a prestigious program and it's my privilege. So it's already 9:16. So without much ado, so let's move on to the topic of today. Is my screen visible?
Yes, you have to go to the full screen mode.
Got it? To me, it is visible. The full screen mode is visible. Is it visible to everybody else?
Not yet, Dr. Himagirish.
Right.
Put on the slideshow.
I put it on. Let me just slideshow on
so maybe you can close it and reopen it again, sir.
Okay.
Yes, sir. We might need to reopen it again.
Okay. Stop share. And then I'll close this now. Now I have to reopen it, right? Okay, let me see if putting it on the slideshow mode now. So is everybody seeing the slideshow or is it still the old mode?
Old one only.
Okay, shall we go ahead with the old one?
Yes,
Okay.
yes.
Fine. Right. So a little bit about reoperative thyroid surgery. So let's look at the magnitude of the problem. What is the cytology of nodule? Why does a nodule recur? How do we evaluate? When do we operate a recurrent nodule? And then what are the surgical approaches, what are the adjuncts we use, stuff like that over the next 15 minutes or so. So about 1.5 to 46% of recurrence of goiters is seen. It was seen in the era of the subtotal thyroidectomy. Of course, over the past 3 decades or so, we've jettisoned subtotal thyroidectomy, and most of the surgeons have gravitated towards a total thyroidectomy or a hemithyroidectomy in case of a solitary nodule. And once that has happened, this is almost zero after total thyroidectomy came into mainstream. Out of the recurrences, those that need surgery have been reported, the reports have been very variable. Some studies have reported maybe 1 in 5, while some other studies have reported that almost all the recurrences have been operated. There may be some selection bias in this. With time, recurrence of nodule after a subtotal thyroidectomy at 5 years is 20%, but at 10 years it's 50%. So you let a thyroid be, and with time, most of them develop nodules. This is sort of in sync with the finding that 1 out of every 2 persons above the age of 50 will have some nodule or the other in the thyroid if we take the trouble to go and do a thyroid scan for the population. Do we need to address all these things? Of course, we don't. So the common causes of recurrence, patients who undergo... Yeah.
Just, sorry to interrupt. The slide is not moving, even in this mode. Tech team, can you help? Stuck up in the first slide.
Okay.
Sir, I'll just see. From here, I'll remove you from sharing your screen. You can share it again.
Okay. Okay. Shall I share the screen now?
Yeah. Yes, sir.
Good. Okay.
Is it visible now?
Yes.
Okay, let's see if it moves. Is it moving?
It's come on screen.
Yes.
Yes, sir. Yes, sir.
Okay. Right.
Yes.
Okay, so the causes for recurrence. Most of the time, patients who undergo a hemithyroidectomy for a presumed solitary nodule, it might have been a dominant nodule of an MNG, and the other small nodules which were left over, they might have grown. Some people undergo nodulectomy or enucleation. This has been happening. This used to happen probably 5-6 decades earlier. Nowadays, with the advent of this minimally invasive thyroidectomy, there is a danger that these things could recur. Considering that overall, as thyroid surgeons, we are still, keeping our baby steps in the field of minimally invasive or scarless thyroidectomy, as it were. Patients who undergo an isthmusectomy, that is anything that is less than a total thyroidectomy. This could be a main reason for recurrence, one of the reasons. A retained pyramidal lobe, this is the most common cause in patients who undergo a total thyroidectomy even. It could be either a recurrent benign nodule, it could be malignancy. Most of the time, these patients present with dysphagia because there's something, there's a sensation of something stuck in their throat while they swallow. Thyrothymic rests, these are rests of thyroid tissue that are present in the thyrothymic ligament. And there's a classification. The rest can be almost just an extension of the entire thyroid, or it can be totally distinct from the thyroid entirely in the retrosternal region, as the various grades are shown here. So the thing to do here to prevent this is to make sure that we go and dissect down to the suprasternal notch. So that way, the chances of trying and taking out the thyrothymic rests are maximum. Make sure that we go and expose the thymus. And when we are retracting the wound from the neck, as we go down, we find the thymus. And once we see the thymus, which is a distinct sort of a lobule of fat amongst the retrosternal tissue, once we are sure that we have the thymus in our sights, that is when we go and stop when we are doing a thyroidectomy. Tubercle of Zucker-Kandel, this is a large protuberance on the posterolateral border of the lobe. It's near the exit of the recurrent ganglion nerve. Sometimes what happens is in our anxiety to prevent injury to the nerve, in our anxiety to preserve the nerve, we leave a little more tissue than we would like to. So this is the risk of tubercle of Zucker-Kandel leading to a recurrence. Sometimes there can be the superior parathyroid gland adjacent to the nerve. And again, in today's day and age, where parathyroid is king as far as thyroid surgery is concerned, we would like to leave the superior parathyroid intact with its blood vessels. Sometimes we leave part of the thyroid, and this may lead to a troublesome recurrence later. Malignancy in remnant, it's quite common in thyroid nodules after the age of 50. 1 in 5 nodules have proved to be malignant. This is as per a recent study in England. So there can be a loco-regional recurrence after thyroidectomy for malignancy as well. So this is another reason for recurrence. So how do we evaluate? The patient comes with a scar and a visible nodule to the OPD. First thing we do is get an ultrasound. We grade it by TIRADS. And there are certain other uses, certain other things we do with the ultrasound. Maybe a contrast enhanced ultrasound will help us make out whether the nodule is something that needs attention or not. In case of troublesome nodules towards the root of the neck, or if we suspect a retrosternal extension, the best thing to do is a CT scan. Very little use of CT scan in patients with nodules entirely limited to the neck. Having done that, always prudent to evaluate the cords. The patient has already been operated, and it is best that we establish the functional status of the cords before we go in again. And as Dr. Anis was saying, I agree with her. The risk of injury to the recurrent laryngeal nerve and palsy to the cord significantly increases in case of reoperative surgery, even in expert hands. It's the best important to evaluate the cords. So what do we look for? What are the reasons for going in again in patients with recurrent goiter? Not everybody needs a second surgery. If we find that the nodule is growing significantly, say about 1 centimeter or so every year, we put the patient on surveillance, at least a scan at least every 12 months. And if we find that the growth is significant, if it's more than 1 centimeter along the greatest dimension, the growth of any particular nodule, that could be a cause that could influence us to talk to the patient about having to undergo second surgery second time. Diagnosis of malignancy, postoperative diagnosis of malignancy after hemithyroidectomy. Sometimes in about 14 to 15% of the time, our preoperative FNAC can be false negative. Suppose there's de novo malignancy in the remnant thyroid, recurrent malignant disease. So these are some of the reasons for operating. Sometimes a nodule which was earlier benign might develop toxicity, and the nodule might grow and lead to pressure symptoms. So these are some of the indications for reoperative thyroidectomy or revision thyroidectomy. So how do we do it? A little bit of surgical details. Of course, there aren't many surgeons here, but a little window into what we do on the table. Generally, the standard approach for thyroid is to go in the midline. We employ a Colles-Crease incision, we divide the platysma, and then we divide the investing layer of deep fascia in the midline. And then having done that, we expose the isthmus of the thyroid, and then we retract the muscles, and then we approach the lobe of the lateral lobes, we expose the lateral lobes, and then go to the poles. This is the conventional thyroidectomy. But as opposed to that, in reoperative surgery, the thyroid bed is all scarred. It's already been operated, so it is not virgin. It's a little difficult to operate. Most of the surgeons do not reflect the sternomastoid or do not employ the lateral approach. So what we do is, it's like the back door. So instead of approaching the thyroid from the front, we approach it from the sides. We catch hold of the sternomastoid and we reflect it. We expose the carotid sheath. What this also does is it frees the lateral lobe of thyroid from the carotid sheath. Sometimes what happens is there's a lot of scar tissue that we are operating on. Right next to it is a very pliable, very delicate internal jugular vein. So in our desperation or in our effort to get the gland out, we might use a little more force than necessary. And in the end, we might end up injuring the internal jugular vein. So this can be prevented by reflecting the sternomastoid and making sure and pushing the carotid sheath away from the thyroid. Where do we look for the nerve? So there are three places where we look for the nerve. There are three approaches: the inferior approach, the lateral approach, and then the superior approach. So the inferior approach is in the root of the neck, where the nerve is a little away from the thyroid, and the tissues around the nerve are more pliable, and it's easier to identify and dissect the nerve. Having done that, we follow the nerve proximally towards the parathyroid region, and then into the entry point where it exits the neck and enters the larynx, that is just caudal to the cricothyroid cartilage. So this is one way of doing it. Start off below and then go proximal. The other way of doing it is classically, the first thing we do when we expose the thyroid is to go for the superior pole, because we all know that 80% of the blood supply to the thyroid comes from above, superior thyroid artery. So once we take care of that, the field becomes far less bloody. The field becomes much easier to manage. Anywhere there's blood in the field, that's an enemy of the surgeon. It's difficult for us to identify those structures. So paramount for us to keep the field as bloodless as possible. And this is why we go for the upper pole first. So when we go for the upper pole, the first place where we encounter the nerve is the point of exit into the exit from the neck and entry into the larynx. And then we can sort of dissect back towards the origin. The easiest way is a lateral approach, where we retract the thyroid, retract the lateral pole of the thyroid, the lateral surface of the thyroid medially, the lateral border, and then we find the nerve somewhere in the middle over there. Use of intraoperative nerve monitoring is paramount, and it helps us identify the nerve, and thereby it helps us prevent nerve injury. Does nerve monitoring itself prevent nerve injury? No. It enables us to identify the nerve better. And as far as parathyroids are concerned, we do what is called as a capsular dissection. So we dissect on the anterolateral surface of the lobe. As far as possible, try and keep the parathyroids away from the dissection. It's like opening the page of a book. And then it is the read of the book where the parathyroids are present. So we sort of dissect on the fascia, and then we turn the fascia away like we turn the page. Of course, identification of parathyroids with the naked eye is paramount, is of paramount importance. And avoiding dissection lateral to the parathyroids, that is again important, because the blood supply comes from behind and lateral. There are various adjuncts for identification of parathyroids, like the use of indocyanine green, ICG fluorescence. There's this Firefly technology where we use infrared light, and having injected indocyanine green into the cubital vein, 5-10 minutes later, the parathyroids light up, and the lit parathyroids are better visualized with the near infrared light. And nowadays we are encountering this phenomenon called autofluorescence. Any tissue that is rich with mitochondria tends to emit light, and this has been found to be the case, particularly in the case of the intact perfused parathyroids. So again, we use a particular frequency of light, a particular wavelength of light, and by employing this, we can see that parathyroids they glow brightly in contrast to the surrounding tissue in the neck. These are all emerging technologies. This has been maybe indocyanine green over the past 2-3 years, autofluorescence from the year 2025. Still in its infancy, and these might assume a major role in thyroid surgery in the coming days to come. So the significant risk of recurrent laryngeal nerve injury as well as hypoparathyroidism after revision thyroidectomy, we can see that it's almost a 5-fold increase in both these cases, in both these complications. So coming to the end, to summarize, there are definite indications to go in as far as recurrent thyroid nodule is concerned. Only about 20 to 25% of recurrent nodules need re-exploration. Maybe a malignancy, maybe malignancy de novo, maybe a recurrent disease, maybe toxicity, maybe pressure symptoms. These are some of the cardinal reasons for going in. Talk to the patient, impress upon them that even in the hands of experienced surgeons, there is a significantly increased risk of the important complications. Various SOPs that we use and employ on the table to make sure that the result is optimum. And communication with the patient. That is what keeps us safe and the patient safe. Again, thank you very much for this opportunity. Thank the Indian Thyroid Society and the conveners of the thyroid clinics. Thank you. Happy to take any questions.
Thank you, Dr. Himagaresh, I think for highlighting the challenges faced with the reoperative thyroidectomy as compared to normal thyroidectomy. I think you have highlighted that the chance of injury to recurrent angina or parathyroids are also more, and we have to be careful. Any questions from the panel members?
Right. Thank you very much again.
Thank you, Dr. Himagaresh. Over to Dr. Pranavi.
Yes, sir. So as we've come to today's end of today's session, I'd like to invite Dr. Pramila Madam to share the closing remarks. Over to Madam.
Thanks, Dr. Ganvi. And I think we had a nice discussion on pediatric graves, followed by the excellent quiz, and then obviously the talk today on the reoperative surgeries. So I think we had a lot of insights into all the varied things, including the pediatric graves and the difficult surgical topic. So I think today was an insightful meeting, and we had the quiz winners as well. And we'll be sending the certificates to them very soon. I think the quiz winners have shared their we have shared the names of the quiz winners. Yeah. So now, and also a request for everybody, because we have this journal of the Indian Thyroid Society, which is the Thyroid Research and Practice, and we all request you all to submit your research to the journal so that we can make it even better. We will be soon getting the indexing of the journal as well. So please submit your research to Thyroid Research and Practice, and I request the faculty who are eligible to please become a reviewer with the Thyroid Research and Practice, because we also need reviewers to review the articles as well. So with that, I hand it back to Dr. Ganvi to continue the proceedings and the final remarks.
Yes, ma'am. I thank our moderators, Dr. Srinagesh sir, Dr. Muthukumaran sir, for a very elaborate discussion and steering the discussion so elegantly for an excellently presented case by Dr. Kavya, and to our speaker, Dr. Himagaresh Rao sir, for a very thought-provoking presentation, and our quizmaster, Dr. Anis Joseph, for making this session, in fact, truly engaging. So our next thyroid clinic session is scheduled for November 12th. I request one and all who have joined today to join us for the next session as well. So with that, we are coming to the end of the session. I thank everyone for joining today, and we look forward to seeing you the next time. So with that, we conclude. Thank you.
Thank you very much.
Thank you, sir. Good night.
तस्य भासय सर्वमिदं विभाति।